Thank you everyone for taking the time out of your evening to join us today for a talk on iron deficiency anemia. My name is Jyoti Nanda. You must have seen my name in all of the email correspondence. I work with the Zio Plus. We are the distributor for Ferrocin Forte, and I also have my colleagues Derek and Faraz Nomani on the call as well. Okay, so just a little bit of housekeeping before we move into introductions and the presentation. So in terms of any questions that you have, please feel free to add them into the chat throughout the presentation. We'll be taking a note of them and adding them to a list, and we'll do our best to get through them at the end of the presentation. So just make sure you're inputting them as we go. Anything else? So in terms of our flow for tonight, we're going to be moving into the presentation with Dr. Furmli. We'll then have the Q&A, and then we're going to have a raffle afterwards. So in order to claim your prize, if you win the raffle, you're going to need to be there in order to say, hey, I'm here. So just make sure you hang on afterwards. And then for anyone who's interested in learning about Ferrocin Forte, if you're not already familiar with our liposomal iron, you can hang on afterwards, and we'll be presenting a little bit on that. Okay, so with that being said, I am going to introduce Dr. Furmli. So Dr. Suleiman Furmli, he practices primary care at an urgent care clinic in Toronto called Town Clinic, and he obtained his medical education and residency in family medicine at the University of Toronto. Dr. Furmli practices as a travel medicine physician, both virtually and on-site in Ajax, Ontario. He enjoys entrepreneurship and innovation in healthcare and is the Chief Medical Officer for careclinic.io, a personal health record and engagement app designed to help patients keep on top of their health. Dr. Furmli is an avid proponent of continuing education and continues to mentor and coach future trainees to reach their full potential. Thank you so much, Dr. Furmli, for joining us today. We're so happy to have you.
Thank you so much, Jyoti, and thank you for all our colleagues, everyone joining with us today. As Jyoti mentioned, my name is Suleiman. I'm a general practitioner, and I'm really excited to be here and to share with all of you what I believe is the next biggest breakthrough for treatment of iron deficiency anemia since IV iron. So, every decade or so, there's something comes on into our realm that helps to change the paradigm for treatment and for patient care. And for iron deficiency, there hasn't really been much, in my opinion, since IV iron came out. So I'm really excited to be here and sharing this presentation and the information with all of you today. So let me just see. Oh, there you go. Okay, so in terms of what we hope to cover, I just want to do like a quick overview of all the basics of iron deficiency anemia, which most of you already know. So I don't want to preach to the choir too much. And then really going into understanding how iron is absorbed. And I think that's key to then understanding how liposomal iron, which will be the main topic of today, or the main new piece of information, really compares with our current standard of care. In terms of conflicts of interest, so today's presentation was made possible through financial support from Zio, and they are giving me a very modest honorarium, which obviously I'm thankful for, but it probably wouldn't even cover my renewal for my CPSO licensure. So, long story short, I will have to keep my day job. And more specifically, as of today, I'm not actually aware of any other company or brand outside of this one specifically that actually carries liposomal iron. So in a way, I kind of didn't really have a choice. Again, not to offend my Ferrocin colleagues, so just going into a few typical cases of what I would commonly see. So this is just a quick list I just came off the top of my head of the types of patients that I see, and I'm sure all of us see, that have iron deficiency. As we know, really the big brunt of iron deficiency, it very disproportionately affects women more than anyone else. So, again, quick side thing for all, big shout out to women, because they are the ones that are essentially taking one for the team for helping ensure the survival of our race. So every time women are menstruating, carrying a child in their belly, during delivery, after delivery, there's a lot of blood loss in this system of procreation. So that causes, eats up a lot of iron stores. And then in addition to, that process, there's also a lot of losses of iron in people with GI conditions. There's a lot of picky eating from children now, and just general, the overall diet consumption in most countries right now are just very much deficient in good vitamins and minerals, including iron. And then obviously there's the other class of patients as well that have chronic diseases that affect iron absorption, specifically patients with gastrointestinal conditions, patients who are taking medications such as NSAIDs that causes bleeding sometimes in the GI tract, and proton pump inhibitors, which decrease the acidity in the stomach, which is sometimes needed for good iron absorption. There's perioperative patients as well. So there's a whole host of different reasons why we might see a lot of patients with iron deficiency. And it is obviously a global epidemic. It's about 2 billion people in the world have iron deficiency, and about half of them have iron deficiency anemia, which is just when the iron is so low that it starts to affect the production of red blood cells. And, again, disproportionately affects women and children. In terms of signs and symptoms, again, these are things we commonly see and we're all very familiar with. So I don't want to spend too much time on this, but in my mind, I usually kind of categorize it into 3 different areas. There is usually all the skin changes because iron is used in rapidly growing cells. So people with iron deficiency may have pallor in the skin, in their conjunctiva. They'll have nail changes. They'll have hair loss. Angular cheilitis, atrophic glossitis, things like that. And then the second category in my mind is usually more functional. Sorry, I'm just getting a message here on the slide. Oh, never mind. So there is the second category are more like functional symptoms, so fatigue, weakness, cold intolerance, dyspnea, and then the last category in my mind is usually things like psychological and cognitive symptoms of anemia, which is things like headache, cognitive dysfunction, poor work productivity. Pica is an interesting one. Actually, I remember personally my mom went through a time when she had a craving to chew on raw, uncooked rice, and it was very odd, seeing her just chewing through and just kind of crunching this in her from time to time. And we realized that it was because of the change, because of the pica, which was because of a secondary to low iron, and then also symptoms like restless leg syndrome as well. So I see a few messages about the slides not being seen. So I'm not sure.
Hey,
Sorry,
Yeah, go ahead.
Yeah.
Dr. Furmli, okay,
Oh.
so some people can see them. I think that maybe if people are having issues,
Okay, thanks to all the other people who quickly replied saying that they can see it. So, okay, so it seems like it's not a systemic problem.
yeah,
You
I
are
would just say if anybody can't see them, there is a drag. There's between the video and the slide, there's a little line where you can drag it. Perhaps they can try to drag it more towards the right and enlarge the slides. Hopefully that helps. Okay.
And also just FYI, I do believe that the presentation will be recorded as well, and maybe the slides might also be available later. So again, my apologies to anyone who's having trouble seeing the slides. And I especially apologize because my voice is also so monotone. So probably not so great that you can't see the slides.
You know what,
Slides
Dr.
are small.
Furmli,
Yeah.
sorry,
Yeah, go ahead.
why don't you try unsharing the screen and then sharing it again?
Yeah, sounds good.
Let's
And
just
what I'll
try that.
do, yeah, what I'll do is also disconnect it from my from my other monitor. Maybe that could be why.
Yeah.
So let me try doing that. So unshare. So it says sharing is paused. So stop sharing.
Hmm.
Okay, and then share screen and PowerPoint. Okay. Okay. All right.
How is this for everyone? Is there anybody who is still having any issues? Okay, perfect. It's
Oh,
good
it's
now.
better. Oh, okay, okay.
Yeah.
Okay,
Thank
so
you,
my
everyone.
apologies.
Apologize for that.
My apologies. Thank you for everyone for bringing that to our attention.
Okay,
All right.
let's
So
go.
now my head is small now, which is great. Yeah, really, you will not find any benefit whatsoever from my head. So thank you for pointing that out. I hope that hopefully everything will be good. So moving forward. Oh no, my head's big again. Oh my God, I'm so sorry. Okay, so I'll try to carry through, and then again, hopefully the recording or my monotone voice will help. Oh, he says I did it again, so I screwed it up again somehow. I think was it just maybe
Dr.
uh,
Furmli, did you move it back onto your main screen?
no,
Like on
no,
YouTube?
no, I didn't really. Here, I'll try to stop it one more time, and then share it one more
Sorry,
time.
everyone.
PowerPoint, hold on, maybe. Um, Moving. Okay, maybe it's
Yeah, you know what? I think you're doing it
maybe
fine. I think that it's just
maybe it's
the
this.
slider in the middle that people need to adjust
Is
on
it
their
this
own.
one? Is it working okay?
Yeah, let's
Yeah.
keep
Okay.
going.
Okay. All right. All right. Sounds good. So oops. Oh. So in terms of the lab workup, um, again something that everyone is pretty familiar with, but essentially ferritin usually is the most helpful indicator of overall iron storage and stores in the body, except for when there's inflammation in the body, because it can also be artificially inflated due to inflammation. But ferritin is quite good. It's almost similar to like TSH in thyroid, understanding someone's if they're hyper or normal thyroid or hyperthyroid. Hemoglobin is also a good marker as well. And if there's still any doubt regarding whether somebody is anemic due to iron deficiency or what their level of iron deficiency is, these are some of the other markers like such as transferrin, total iron binding capacity, total serum iron, transferrin saturation, and then the MCV as well can help. And then this little diagram on the right just shows pathology, a blood smear of hypochromic anemic cells, which thankfully we don't have to read these smears on a regular basis unless any of you guys are a pathologist. In terms of the main current standard of care for iron deficiency is diet changes in diet, oral iron supplementation, IV infusion, and blood transfusion. And what I really want to share in this slide is basically to discuss the challenges with absorption of oral iron, including from the diet or from regular oral salts or oral supplements that we can purchase. The main, I guess the main point in terms of looking at this diagram is that it takes a lot of different steps for iron that comes through the gut to be actually metabolized and finally bound in the last form to be joined onto transferrin to then be distributed to the rest of the body where it's needed to produce red blood cells and other functions. So first of all, the amount of space that can be used for absorption, it's really only the duodenum. So anyone who has any duodenal issues or gastric bypass patients or things like that, they don't really have much real estate in order to absorb iron. The second thing is that the transport of iron into the body or the for the enterocyte to actually take in that iron, it's very much dependent on these transporters. And there's at least, as you can see from this diagram, depending on whether you're talking about non-heme iron, which is mainly iron that comes from non-animal sources, where the max absorption is only about 10%. And then you can see on the right here, there's heme iron, which already comes sort of bound. and has a different transporter. But all in all, when they come inside of the enterocyte, and assuming they can actually cross the transporters, they then have to be oxidized, reduced, and then transferred into the bloodstream, and then again oxidized here from the ferrous form to the ferric form, and then finally to transfer in the bloodstream. So all of these steps have a lot of different rate limiting steps, which actually prevent iron absorption and end up causing a lot of side effects as well. And so that's why a lot of the oral medications have to be dosed in higher amounts. They might need to be administered multiple times a day. They might have to be co-administered with things like vitamin C or other acids to help with absorption. And they must be taken with food, again, to help with tolerability. So it really limits how much and how effective it can be to help the average patient. So wouldn't it be nice to bypass all of this sort of very inefficient method of absorption? And that's exactly what happened about 10 to 15 years ago when IV iron came onto the scene. And I still remember as a resident having presentations about it because it was very novel at that time. And it just seemed too good to be true. And really it is, if you compare it to what was available at the time, which was literally blood transfusion. So what are the benefits of iron in bypassing the enteric system for absorption? It's very fast acting. You'll see rapid improvement in hemoglobin in days to short weeks. The infusion times have gotten better and better since they first came on the market. A better tolerability because you're not dealing with all the rate limiting steps in the gut. And it can be used for patients with comorbid conditions. So patients with gut diseases, cancer, kidney diseases, etc. And again, it's really nice that it helped to avoid so many blood transfusions since then. So having said all of that, there are still some downsides. Specifically, there's a lot of healthcare resources that are needed in order to administer IV iron. And so overall, there's higher costs because you need IV access, you need some nursing care. It has to be done in a medical setting. It is somewhat invasive. So for children or people with needle phobias or patients with poor vascular access, it might be challenging to use. There is some risks, however, it is quite low, but there are some risks of hypersensitivity reactions, including anaphylaxis. There's some hypotensive reactions, there's some extravasation type of reactions. And again, so there are some barriers to access. You do need a physician to prescribe it. You need some specialized settings, appointments. And in the long term, it's not, it's kind of cumbersome in the long term because you do an IV iron infusion, then maybe a few months later, you have to go back and that just have to kind of keep going. So it's not as sustainable in that sense. And it doesn't always come with some of the other nutrients that might be needed for someone who might be iron deficient, such as B12 and things like that, which a lot of times can co-occur. So wouldn't it be nice if we could have our cake and eat it too? So that's kind of the cool thing and what's really fascinated me about both in theory, understanding how liposomal iron works, and also seeing it and deploying it within my own eyes in my patients. So the idea and the benefit and the novelty in the liposomal iron is that it combines the advantages of both the IV and PO forms without the disadvantages. And that's the really cool thing about liposomal iron. So in this slide, I'll just sort of explain very high level how it works. And really, it's not very complicated. But conceptually, we'll all understand why this method or this molecule is actually much more easier for absorption and more effective. So the first part is what's in the core. So you see here in the red sphere here in the middle, that's the actual form of iron, which is in the form of ferric pyrophosphate. So if you remember from the previous slides, the ferric form of iron, which is the Fe2+, is actually the currency of iron that's used in the body. That's the final form. So this is just sitting, just ready to hit the ground running. It doesn't need to be oxidized or doesn't need any more modification by any transporters in the body. The second layer is the phospholipid bilayer, the liposome. So the novelty about this is that it allows this molecule to actually be endocytosed and engulfed by macrophages and by the cells that are responsible for absorbing it. And in fact, this is actually how iron is recycled and metabolized in the body. So our body is very efficient at recycling iron from our red blood cells. Every time our red blood cells are broken down by macrophages, about 95% of the iron is engulfed and recycled in those macrophages in the lymphatic system. So putting it in being able to put it in a phospholipid bilayer allows the cells, it completely bypasses the whole system of needing transporters or cellular receptors to take care of the uptake. It just gets engulfed very, very easily, and as per what the natural sort of iron metabolism is in the body. The third layer on top is the LCE coat, and then there's another coat for maltodextrin. So essentially, these help to stabilize the overall molecule and also help to protect it in the gut from the digestive enzymes and the overall environment to make sure that the molecule is not is still stable and able to be absorbed. So this diagram helps to actually show how the liposomal absorption system is completely different from the from regular oral absorption. So the first point here is that the cells that absorb and endocytose the iron and liposomal iron are called the M cells, and these are part of the lymphatic system that are present within pairs patches that actually circulate and are present throughout the entire small bowel. So first of all, it means that you have a lot more real estate than just the duodenum to be able to capture the iron across the GI tract. And then obviously number two is that it completely bypasses all the receptors and all the oxidization and reduction and all the other things that can impair and rate limit the absorption of iron. It's just basically swallowed up through endocytosis. And the second advantage is that it goes straight into the lymphatic system. So it completely also bypasses the bloodstream as well. And as you may know, the lymphatic system is actually the system which helps to process iron and actually help to produce red blood cells and recycle red blood cells. So that includes the spleen, the bone marrow, the liver. So it's quite amazing. So all of this in theory obviously sounds good, right? But anybody can make a nice diagram like this and a nice molecule and make it sound good. But does it work in the real world? That's really what we all care about and what I care about. I always say to everybody, the proof is in the pudding. And so there's a whole host of studies showing the usage of liposomal iron. This one is nice. So it's a randomized control trial. I think it's in a setting in Europe. I believe it's in Italy, if I'm not mistaken, where they took patients from 2 academic centers and 1 family medicine outpatient setting, and they randomized them to sucrosomal or liposomal iron versus IV iron. And as you can see from the chart here, that the benefit was almost equivalent in both cases. And within a matter of about 28 days, the overall hemoglobin levels improved in both groups from about 80 to about 120, which is a target range. So roughly that's about 10 units of hemoglobin per week, which is quite impressive. I mean, it's not that impressive for the IV iron, we already kind of know that, but it's quite impressive for the oral liposomal iron to be able to mimic that trajectory. And the best part is it doesn't just work on regular patients with sort of your bread and butter garden variety decreased iron. It actually has been used and tested in many chronic disease and very sick patients. And it's still shown it's as effective as IV iron. So and that I think is very telling and powerful as well. So you can see some of the studies, used in chronic kidney disease patients and inflammatory bowel disease patients, in cardiac patients, in patients undergoing cancer with chemotherapy, patients with undergoing bariatric surgery, and even patients going through hip replacement and other sort of bloody, I guess, otherwise surgeries. This is just like an overview comparison chart of sort of some of the advantages and disadvantages of the 3 main types of iron that are available on the market. So regular iron salts, IV iron, and then liposomal iron. So as I mentioned, that it kind of combines all the benefits of each of both of these without many of the side effects or downsides, which is quite helpful. In terms of practical prescribing consideration, so any of us as prescribers, we have to be very mindful of a whole host of things whenever we want to prescribe any or recommend any product to any patient. Obviously, one of the first ones is affordability. We do not want to prescribe a medicine for a patient that they can't afford. So, we always ask patients what's their drug plan, what's their socioeconomic status, to make sure that what we recommend reflects that. So that's very important. And I'll show you the price comparison chart in the next slide. Availability, right? How easy, or also accessibility. How easy is it for patients to access that? Because if it's not very easy, then obviously your compliance will drop right away. So the nice thing about Ferrosome, which is the only currently in Canada, the only liposomal iron that's on the market. It's over the counter. It can be picked up in pharmacies. All Rexall pharmacies carry them so far. To my knowledge, it can be ordered directly through their website. Can be fulfilled through Amazon. In terms of efficacy and speed, we want to make sure that whatever we're prescribing will actually work and be in terms of being effective and being able to work fast. Because as you know, also in terms of tolerance and tolerability, a lot of patients, if they don't see quick results, they'll also probably just drop and stop taking the medications, right? So that's why it's good to have something that can show results very quickly, which we saw with being comparable to IV iron is a huge plus in terms of the speed. The fourth thing is that it's not animal based. So for us, I saw a lot of the cities, a lot of us are from metropolitans within Canada where there's a very diverse set of patients. So it's very nice that it's friendly to patients with all types of dietary restrictions, vegan, vegetarian, kosher, halal, because it's not animal based at all. It comes in both pill and sachet form or powder form, which means that it can be used for, adults and children, or people who are not able to swallow tablets for any reason. And the sachet form is really nice because it also has folic acid, 0.4 milligrams, which is what's needed for pregnant women, B12 and vitamin D as well. And like I mentioned, especially B12, it's commonly deficiencies in this commonly might co-occur with iron deficiency. So it's nice to have them both in one. And then in terms of typical dosage, so practically speaking, for my patients who are very anemic, who kind of need quick, very low ferritins, low hemoglobins, and especially if they're showing any physical symptoms of iron deficiency, I usually recommend taking either one tablet or one sachet twice per day, usually for about 2 weeks until their levels normalize. As you guys saw in the other study, that it's usually 10 units of hemoglobin per week of taking the liposomal iron. So, and then after about 2 to 4 weeks, I just recommend them taking it just once daily. So the company, so Ferrosome, which we'll speak shortly, they actually offer a complete money back guarantee, so that it's not just like they're so confident, and as the evidence mentioned, that there's it pretty much helps almost everyone, and so they're so confident that they're willing to give anyone back their money that doesn't find that it's beneficial, which again, it's few and far between. This product is made in Canada and is Health Canada approved. And as I mentioned, it's the only product on the market in Canada right now, although it is common in Europe and Asia. So if you actually search liposomal iron online, you'll find a lot of companies that produce it, and it's been in use for at least 5 to 10 years in Europe and Asia. It's just that in Canada, it just hasn't reached Canada. I'm not sure why. And I just want to put an honorable mention to another product that I do commonly use for iron deficiency, and this is called Lucky Iron Leaf or Lucky Iron Fish, which many of you guys must have seen already. He had a really good TED talk about the story behind it, which is really touching. It's created by the Canadian Dr. Christopher Charles, who noticed higher rates of iron deficiency in Cambodia. And he actually produced this type of iron that can be put in your pots at home when you're creating food, or if you want to boil it and use it for different shakes or things like that. So I also, in addition to Ferrosome, I usually also recommend Lucky Iron Leaf because it's a nice different way to incorporate the iron in their diets at home when they're actually cooking. And the other nice thing I like about it is that a lot of the times, iron deficiency, it kind of gets passed on to children and generations. So the cool thing about it is that it can treat the entire family, which I also like. So just wanted to mention that as well. In terms of, so this is affordability, the cost effectiveness of ferrosome, which is a liposomal iron, just compared to some of the main other players in the market, like Ferromax, Optifer, and Palifer. So you can see that it's just slightly more expensive than Ferromax. And compared to what patients are actually getting, which is pretty much an oral form of IV iron, I would say that's quite fair, and it's a steal. And I guess it also makes sense. I don't know much about how the manufacturing works or the cost for manufacturing, but I can probably imagine that it probably would cost a lot more to make a molecule like this compared to just regular elemental iron, or just an iron salt like how Ferromax is made. So these are the two forms that it comes in Canada. So the first one is the capsules, or the pill version, and then there's the sachets, which is the powdered version. And I think we kind of discussed, like I mentioned, the nice thing about the sachet version is it has both the vitamins B12 and folic acid for pregnant women. Just to quickly mention, I mean, professionally speaking, and my own anecdotal experience, it's been quite phenomenal. Like in the past, whenever somebody, it's kind of like, you know, now when people do their vitamin D test, it's kind of like, and actually I personally don't order vitamin D tests, but because I work in a walk-in setting as well, a lot of other physicians might order it, and then I have to kind of share with the patients that, okay, you have vitamin D deficiency. And you know, it's like the nice thing about, until now, I always kind of felt a little bit like is difficult to treat iron deficiency. I didn't want to send patients to get IV iron because of, you know, how difficult it might be, especially in an outpatient setting. So I was always trying to help counsel about the diet and oral supplementation, but really most patients would tell me that they already tried all of that. They tried increasing their diet, they tried taking the salts, and they couldn't tolerate it, and they're all quite frustrated. And so until I actually learned about this product, I felt quite you know, kind of handicapped in how much I could actually help people. And it wasn't really a nice feeling. And then after I heard about this, I was very skeptical that there could be about this form. And once I actually started doing some digging and learned that it actually works quite well, and it's been used around the world, but just not in Canada yet, I started to experience, you know, try to recommend it to my own family members. You know, my wife was iron deficient, you know, other family members, and also my patients as well, and just saw like very, very phenomenal results. And since then, it's just, I don't even think about it. I always just recommend this, and not a single patient has come back to me, or have I ever seen their blood work with and their results haven't normalized. So it's very rare that we find like a silver bullet, and patients are always looking for magic pills that can solve all their problems. And so most of the times we can't, as physicians and primary care providers. So it's very refreshing to find options such as these that can be sort of that magic bullet and really help make a difference. And also all my other colleagues who started using them as well, they've pretty much had the same results. It's just completely a game changer. So these are some of the references that show the usage in different settings. And you guys are welcome. I actually asked the Verisome team to kind of compile all of these. So if anyone wants a list of all the PDFs, a lot of the PDFs were like free through PubMed, so they can compile everything and share it and send it to everybody to take a look at the data for themselves, and then decide if they want to use it or not for their patients. But I just want to, at least at the very least, my goal for today is at least just to share it with everyone, just so everybody know it's there. And then you know, what you choose to do, and you know, everyone should do their due diligence and make sure that they're comfortable with it. But I guarantee everyone they would really benefit from using this for their patients. And all of you will look good, and then hopefully you guys will remember a humble GP that shared the information with you one Tuesday night. So that's it for me. Thank you so much for your attention, and I guess we can jump to questions now.
Hey, Dr. Furmli, thanks for the great presentation. We have a ton of questions that came through, so I will just start. I'll just go through them one by one, okay?
Okay.
So first question here, in terms of supplementation, I've been told as an RD to only supplement based on low ferritin, not serum iron, saturation, or other markers. Would you agree with this?
So personally speaking, I never use one marker for anything. And especially, I think you had mentioned that she mentioned that she or he or she has to use ferritin, which again, as I mentioned earlier in the presentation, ferritin can actually be an acute inflammatory marker. So you could have somebody with high ferritin, but be very low in iron still. So basically, from my opinion, and you know, the long story short, it's never to actually use any one marker for making any conclusions, especially in the case of iron deficiency and anemia. And so you really have to look at all the patient's symptoms, make sure it matches. You want to kind of rule out other things that could be mimicking it, like, you know, thyroid disorders or other things like B12 deficiency. And then you also want to make sure that all the other tests that I had mentioned earlier, they all match. So yeah, don't use any one marker. Really try to take the whole patient as a whole. And the other thing I always say is, like, we're not here to treat numbers, we're here to treat patients. So that's also why whenever I have abnormal lab results and either the patient is concerned or someone else might be concerned, I always tell them that it's never good to hang your hat on any one number. Let's look at the entire picture and try to come up with a good approach.
Okay. So next question here, how is the absorption in colectomy patients who have IBD?
So as I mentioned, the absorption for liposomal iron takes place in the entire small bowel. So again, as long as they have enough small bowel, which most people do, even in IBD, they should be able to absorb it pretty good. And as I mentioned, there's a study actually specifically in patients with both celiac disease and IBD, which shows the effectiveness of ferrosome, and that's in the reference section. And like I mentioned, that the team can be happy to share that PDF with the actual studies.
Okay. Next question. Had a patient on IV iron and had a very bad reaction and turned her skin blue. And after having few injections, she had chest pain and tightness in the chest. Have you seen these side effects in your practice?
Okay, so just full disclosure. So myself, I work at a walk-in clinic, mainly walk-in clinic / urgent care, and obviously I've locumed in other situations, but I've actually never worked in an IV infusion clinic because I'm a GP. So I personally have not seen it with my own eyes. However, based on the research that I've done, like I mentioned, the chances for, and I'm sorry that your patient went through that, according to the statistics that I read about, they're quite rare to have the three reactions I mentioned. So number one is a hypersensitivity anaphylactic reaction. Number two, hypotensive reactions. And number three, the one that you had mentioned, Jody, from the questioner, is it's called the extravasation. So what happens is that extra iron actually pools outside of the blood vessels and causes this kind of discoloration, you know, as you had mentioned. So yeah, definitely, again, it's IV iron is not perfect, but obviously it's done a lot of good and helped a lot of patients. So, but yeah, I'm sorry that your patient went through that.
Okay. What would be the benefits of ferrosome compared to Ferromax?
Sorry, can you repeat that one more time? Sorry.
Yeah.
Jody.
What would be the benefits of ferrosome compared to Ferromax?
Okay, so I mean, compared to that question, I mean, to answer that question, and sorry, sort of anything similar. So Ferromax would kind of fall under the section of PO iron salts, which you can see on the left-hand side. So you can see that the advantages of Ferromax or any other sort of iron salt with Ferromax is that it's pretty cost effective. It's very easy to access it. You know, it's available OTC, but beyond that, there's a lot of side effects to it. So on the right-hand side, if you see the comparison chart with for liposomal iron, you could see that, again, it has all the benefits of the iron salts, which is the accessibility, that's available over the counter, and it has the benefits of the IV iron as well. So yeah, hope that answers that question.
What is the dose of ferrosome for children and adults, and from what age in children can it be used? Is this also based on elemental iron or not?
Sorry, can you repeat the first part of that again?
Yeah. What is the dose of ferrosome for children and adults, and from what age in children can it be used?
Okay, perfect. So I think I think I had a slide on that specifically, but maybe it was taken out. But
Alright.
the so the nice thing is, so it can be used in pretty much all ages. For young children, I think that the lowest, so for children, it would basically be used the sachet form only, the powdered form. And I think it's only once you start hitting weights or ages like below 4, if I'm not mistaken, that you have to just kind of use partial amounts of the sachet. So I think between certain ages, you maybe use half of the sachet, and then based on weight, you may only use a quarter. So
Mhm.
the dosages, I don't know off the top of my head, but I'm sure that the
I just popped them into the chat.
oh, awesome. Okay, thank you so
Yep,
much.
you're welcome. Okay, we'll get to the next question. Another one on children. So how does the side effect profile compare between Ferrosome and other oral iron products?
Um, so yeah, the side effects are quite minimal. Like I don't know, maybe if for regular, I think the tolerability of regular iron salts are somewhere between 30 to 50%, I believe, in terms of side effects and things like that. But with liposomal iron, I believe it's like less than 5%. So very minimal side effects. And again, that's because of the way that it's packaged, the way that it's absorbed through the endocytic system, through the lymphatic system.
How would you how would you recommend patients get started on Ferrosome? Like taking it every day or, every other day to start to get acclimated to the product? What would you suggest?
I usually, depending on how low I usually recommend how much to take based on the level of deficiency. And again, part of that is also considering the affordability part too. Because if someone's iron is not that low and they're not that iron deficient, I wouldn't recommend them to take more than one per day. However, if their iron is really low and they're symptomatic and they're showing lots of signs, I usually tell them to take it twice a day, morning and evening, and they can take it with or without food, whatever's easy for them, because it doesn't have any of the GI side effects that way. It can be absorbed easily either way. And then after about 2 weeks or so, I just tell them to just take it once a day. And yeah, I hope that helps.
Okay. What are the blood work monitoring recommendations after initiation to monitor response? Is 3 months still reasonable?
So in fact, you can actually see changes in the ferritin and the hemoglobin as well before 3 months. So 3 months is the general life cycle for red blood cell production. So that definitely makes sense to order every 3 months from that perspective. But if somebody is very iron deficient and symptomatic, and you really want to make sure that they're able to tolerate it and it's actually benefiting them, you can order repeat ferritin and hemoglobins even within 2 to 4 weeks, and you should see changes. But obviously, you should order it based on your clinical judgment. It might not be needed to order it in 2 to 4 weeks, but my point is that you will see changes in that long. So you can really kind of play it by ear depending on what the need and necessity of uh, the testing interval is based on how the patient is doing. Again, we want to treat patients and not necessarily the numbers.
Okay. Okay, so next question. In a pregnant lady with severe IDA, can one routinely combine the prenatals like Materna with Ferrosome or other iron supplements?
So yeah, absolutely, you can. You can combine them, and so there's no problem at all. So what you could do is, so what I tell patients is that if they're pregnant, they could just either take just one of the sachet forms of ferrosome, because as I mentioned, it has the folic acid, the zero point 0.4 milligrams. It has vitamin D, vitamin B12, vitamin C, as well. So a lot of patients who are pregnant or otherwise might also have co-occurring B12 deficiency as well, and they need the folic acid, right? So usually, again, in terms of compliance, I'll usually tell patients, hey, if you want, you can just take one of these powdered forms, and that has everything you need, so you don't need to shop around or take multiple things. Or I can tell them again that you can, if you want, if you're happy with your regular prenatal vitamin, you can continue with that. And just to fix the iron deficiency portion, you can just take the pill version, or the capsule form of liposomal iron. So I leave it in their hands, and just let them know that both options are fine.
Okay. Just sorting through these. Okay, so I'm not too sure what EPE is, but how is EPE, how does it work in playing a role with ferrosome? Do you know what that means?
I think maybe they meant EPO,
Okay.
maybe instead of EPE. So EPO is a hormone that's used to help to generate more red blood cells in kidney disease, in patients with kidney disease. So it could be maybe that was what their question was. And again, they can take this with EPO as well, because the EPO portion just helps to stimulate the production of reticulocytes or red blood cells, and then the ferrosome will help with the raw ingredients, namely the iron and the B12 to produce it. So absolutely no issues. And then I also, Jyoti, before you go further, I see a lot of questions about side effects, about turning stool black, the metallic taste, all of these. So I just want to clarify that no, with ferrosome, they should not be experiencing any of these typical side effects, such as black stools, constipation, nausea, vomiting, metallic taste. All of those are not considerations with ferrosome, again, because as we explained, it's absorbed in such a different in such a different pathway that it bypasses all of those systems that cause those kind of side effects. So that's the advantage of ferrosome. I hope that
Okay.
helps.
And then this question, I feel like it kind of, it also kind of might talk about the side effects, because somebody's asking, is there any difference in terms of efficacy if taken every other day versus daily, as believed for other available products?
So it's a good question. And again, one of the reasons that regular iron salts are sometimes recommended to do it every other day is simply because taking it every day actually causes upregulation in certain molecules or pathways that actually inhibit the absorption of iron. And so that's why a lot of guidelines recommend taking it every other day to allow the upregulation of the receptors that will then absorb the iron by leaving that gap in between. So really, when it comes to taking liposomal iron, you don't need to take it every other day to help with, to increase the tolerance and the compliance. It's all about how fast you want to increase the iron stores. And then in terms of maintenance, it's totally conceivable that some patients will normalize their iron levels, and then they might not need to take it every single day. They can take it every other day, and maybe even every other day, for sure. And it really depends, again, as a clinician, when you have that patient sitting in front of you and really understanding where their iron deficiency is coming from, that will help you to understand how, and after you see how fast or slow their iron levels climb after taking ferrosome, you'll actually be able to know or have an instinct about how often they can then take it, whether it's daily or every other day, depending on what their needs are. So for example, if you have a patient with lots of blood loss for whatever reason, maybe they just they're postpartum, or they have really bad fibroids or things like that, then you might be able to tell them, okay, no, you should take it every other day because you have a lot of blood loss. Whereas someone else who, after their levels normalize, for maintenance, you might recommend, okay, you should probably be fine with every other day. And you can always test that and confirm that later on to double check.
Okay. So aside from, having a patient who's pregnant, or looking to get pregnant, how would one choose pill or capsule or powder form? So capsule or sachet.
So it's really comes down to two considerations. One, the real differences is the actual tolerability. So some people just don't like swallowing tablets, or for example, children might have difficulty with swallowing tablets, or even some pregnant women, even if they're taking Materna or another prenatal vitamin that has folic acid, but in fact they might have like like Pregvit is a really good example, right? Like Pregvit are like, the pills are so big, they're like horse pills, and they have to take it twice a day. So for a pregnant woman who might be experiencing nauseousness or other symptoms, I usually that's why I usually don't use Pregvid commonly, even though it's covered by a lot of benefits plans. So again, so that's the first thing, right? Is how easy is it for them to take tablets or capsules? And so if they prefer a powdered form, it's easier. It's a drink. It's berry flavored. I haven't drank it. I haven't actually tried it myself, but I hear from my patients that it's very easy to take and pretty well tolerated taste wise. And then the second consideration is whether they need more than just iron. So the capsules only contain just the iron itself and nothing extra, whereas the sachets contain the folic acid, vitamin B12, vitamin D, and also they both contain vitamin C too, which again just helps a little bit with the absorption, but it's not really um, uh, that's like super helpful or super needed as far as I'm aware. But so that's really the main thing is that do they need more than just iron? If yes, then I recommend the sachets. And number two is are they able to tolerate the capsules? If yes, great, take the capsule version. Otherwise, if they have any issues with it, then the powder version works great.
Okay, thank you. So next question here, can it be helpful with anemia, anemia with low ferritin and liver disease, cirrhosis, fatty liver, etc.?
Yes, absolutely. So it's there's no issues with any comorbidity really, whether it's from iron deficiency, from liver disease or otherwise. Uh, it will still be absorbed through the lymphatic system.
Okay, and how about if a patient is on a proton pump inhibitor? Any interference with that?
Absolutely not. So that's one of the other advantages with ferrosome is that because it's absorbed through endocytosis and phagocytosis through the lymphatic system, it completely bypasses all the other considerations with respect to other medications and other things that are being taken at the same time for patients with comorbidities.
Okay. You did cover this lightly at the beginning, but somebody asked, they said they may have missed it. What is the evidence in gastric bypass patients?
So this study here on the top right, if you can see, it says response to oral sucrosilmate iron supplementation in patients undergoing bariatric surgery, and the authors and there. So if I remember correctly, either they compared ferrosome to IV iron in this population, or they might have just used it compared to the regular standard of care, and it was quite effective. And the conclusion in this study, which is similar to all the other studies that are here, actually, they all indicate that ferrosome was well tolerated and has substantial benefits in this population.
Okay. So if using powdered form, so the sachet, are the added vitamins, specifically folic acid, safe for children?
Yep, it's safe to say. So with most vitamins in the body, especially at low doses, the body will pee it out and just urinate it out if you don't really need it. So
Okay.
yep, there's no worry about folic acid toxicity or anything in pediatrics as far as I'm aware.
Okay. Let's see. So with traditional iron supplements, you would continue for 6 months after normal limits of hemoglobin and ferritin are achieved. How long do you continue maintenance dose for liposomal iron?
So I'm not aware of like in my own patients, I don't really I've never like necessarily followed that, okay, just take it for 6 months and then you're good. Again, we treat patients and not numbers. And so I always try to understand the patient sitting in front of me, where is their source of blood loss coming from, right? Because let's say you start seeing a patient in their first prenatal visit, and then you start them on ferrosome, and then 6 months later, guess what? They're going to be closer to delivery, and they're going to have even more reasons for having blood loss after, right? So I don't really use any specific rules like that in my own personal practice. Maybe I'm not practicing the correct way, so my apologies. I'm not teaching anything that's not correct. But like I mentioned, that in my patients, I try to really understand where is their blood loss coming from, and then recommending and basing how long and how much of any medicine to take, including iron supplementation, based on that. based on what their needs are, and always revisiting it, right? So let's say they're having a lot of heavy bleeding, or let's say they're post-op, they're having some operation, and 6 months later they're recovered and their blood loss is limited, then we can revisit to see, do they even need any iron supplementation, or do they need more iron supplementation? So I usually just kind of base it based on that. So unfortunately, I don't have any specific number to give with respect to this question. My apologies.
Okay, thank you. Okay, so the product is OTC, but can you get a prescription from your family doctor in order for it to be covered under insurance?
So to my knowledge, natural, so Ferrosome, like any iron, with most iron supplements, I think there's maybe a few that might be covered, maybe Ferromax or thing, but those ones are mostly grandfathered in. So I don't believe that any prescription would necessarily be able to get it covered, which again is really unfortunate, because
Did we lose Dr. Furmli?
Oh, I thought it was just me. Okay.
I think we lost them. You know, just that question did come up quite a lot with the regarding insurance, and often a lot of private plans with a doctor's prescription and a reason why they're taking it. Sometimes it is covered. So it's definitely something worth exploring with patients either way.
Okay. You know, there are,
Oh, is he back?
hey, there we go.
Okay.
Hey, Dr. Furmli, we lost you for a minute.
Oh, sorry about that.
That's okay. Okay, I'll just move on to the next question. Derek answered the one about the insurance. We'll do 2 more questions just in the interest of time. So let me see here. Is it possible to have high ferritin yet low red blood cells? Is this product good for this problem?
So high ferritin and low red blood cells, yes. So as I mentioned, ferritin can be a marker for inflammation. So if someone has any type of autoimmune disease, or chronic kidney disease or anything of that nature, they could have a high ferritin but still be anemic. So if the reason that they're anemic is from iron deficiency, then yes, Ferrosome will help them. If their blood cell count is low for some other reason, or let's say maybe they're B12 deficient or something else, then unless they take the sachet for version of Ferrosome, or then it will not help. So it's primarily only to help with people who have low iron as the cause of their anemia.
Okay. And last question here. So how long would you consider Ferrosome for patients to see if it works before moving to IV iron?
I would say within a month they should, at the latest. So if you try it for 4 weeks and the hemoglobin is not, depending on how low it is, but if it's not at least 20 units better, and you're sure they're compliant, then I would probably recommend going to IV iron.
Okay, awesome. Okay, well, Dr. Furmli, we're going to leave it at that. We have a few other questions that came through specific to the product that, we can, like pricing and things like that, we can hang on and answer later on after the raffle if anybody's interested. But other than that, I just wanted to thank you for your time and your wonderful presentation. We've received so much feedback throughout the presentation on how people have found it to be very informative and helpful. So thank you.
Thank you guys so much. You've been great. I really appreciate all the questions, thought-provoking questions, and for everyone from all across Canada making it out today on a weekday evening. It really means a lot. But more importantly, I really hope that that everyone here is able to help their patients with this product, and see the benefits for themselves. And I'm so confident, because I know that if you guys didn't see the benefits, I'll probably never be able to show my face again in any future encounter. So that's how confident I am that everyone will benefit. And again, thank you for everything, and hope to see you guys in the future. Take care.
Thank you.
Thanks, Dr. Furmli.
Bye, everybody. Take care.